Hello, my name is Ardaman Shergill, and I'm a GI medical oncologist at the University of Chicago. It is my honor to speak today at the 2021 Cholangiocarcinoma Foundation Annual Conference. The topic I'm discussing is MAP kinase pathway targeting in cholangiocarcinomas. This is the outline of my talk. Cholangiocarcinomas or biliary tract cancers really include three different cancers: the intrahepatic cholangio, extrahepatic cholangio, and the gallbladder cancers. It is important to remember that each site is an anatomically, clinically, pathologically, and molecularly distinct entity. Historically, biliary tract cancers have been associated with poor prognosis. Here, I'm showing the genomic landscape of biliary tract cancers. Higher the mutation on this list, the more prevalent it is in that subtype of biliary tract cancer. For example, FGFR alterations shown with the green arrow are much more commonly found in intrahepatic cholangios compared to the other two subtypes as shown in the green arrows. Similarly, KRAS mutations are much more common in the extrahepatic cholangios as shown in some of the red arrows. When it comes to KRAS mutations specifically, the incidence is higher in extrahepatic cholangios at about 40%, followed by intrahepatic cholangios at about 20%, and gallbladder cancers at about 10%. BRAF mutations are found slightly more frequently in the intrahepatic cholangios. KRAS mutations in cholangiocarcinomas have been related to perineural invasion, advanced stage disease, and worse prognosis overall. Now, the mitogen-activated protein kinase pathway is a cascade of signaling and is one of the most commonly dysregulated pathways in human cancers. As you can see, it's a very complex system. In mammalian cells, there are at least 3 different kinds of MAP signaling transduction pathways which end with 3 proteins, the ERK12, JNK12, and P38, that eventually transduce extracellular signals into the nucleus and induce a response in that cell. MAP kinase mutations often lead to aberrant constitutive activation of the signaling, not only in biliary tract cancers, but it's also seen in other tumors like pancreatic cancer, colon cancer, lung cancer, etc. For the rest of my talk, I will focus on the RAS, RAF, MEK, ERK MAP kinase pathway shown in red circles on this screen. This cascade of signaling is made up of different proteins. There are the RAS proteins, KRAS, HRAS, NRAS, the RAF proteins, BRAF, ARAF, CRAF, MEK1 and 2, and ERK1 and 2. When this cascade is activated due to mutations in the genes, it leads to a signal of proliferation, survival, and metastases to the nucleus of the cell. Now, when it comes to targeting this pathway, we often talk about MEK inhibition for RAS-mutated cancers. It's because MEK1 and 2 have a rather narrow substrate specificity and are only known to activate ERK1 and 2, whereas the upstream RAF proteins and the downstream ERK proteins may have many targets. In addition, activation of this pathway leads to activation of other co-stimulatory pathways, making it even more of a therapeutic challenge. For example, parallel activation of PI3K-AKT pathway is shown here. Due to the role of MAP kinase mutations in tumorigenesis of biliary tract cancer, MEK inhibitors have been studied in biliary tract cancers. Here I've summarized some of the early phase single-agent studies in patients who had relapsed refractory cholangiocarcinomas. As you can see, in this setting, in the relapsed refractory setting, the activity is very modest. The objective response rate was in the 10% range. MEK inhibition has also been studied in the frontline setting. ABC04 was a small 14-patient phase 1 study that evaluated standard first-line chemotherapy regimen used in biliary tract cancers, which is gemcitabine and cisplatin, in combination with selumetinib. Of the 8 patients whose course was evaluable for response, 2 patients had radiographically measurable response. Dr. Lowry's study, the second study mentioned here, also used gemcitabine cisplatin backbone and added binimetinib to that combination. The reported response rate here was 36%. 3 patients had CR, 9 patients had partial response. Among patients who had complete response or partial response, MEK MAP kinase alterations were found in 33.3% compared to 12.5% who did not have a radiographic response. This was a negative study, though, because it did not meet its pre-specified response rate of 40% over 1 year, and it did not meet its pre-specified 6-month progression-free survival rate of 74%. The 6-month progression-free survival rate in this study was 54%. Dr. Lowry did discuss that there may be a need of prior patient selection to see if this kind of approach is useful for some patients, given the responses seen in some patients in this study. What about in the second-line setting? SWOG 1310 was a phase 2 study that compared trametinib to chemotherapy, 5-FU or capecitabine, in the second-line setting in patients with advanced biliary tract cancers. This study unfortunately had to be stopped early due to lack of response in the trametinib arm. In these graphs, blue represents chemotherapy, red represents the MEK inhibitor arm. Both overall survival and progression-free survival seem to be better in the chemotherapy arm. However, in this study, investigators looked at the combination of chemotherapy and MEK inhibitor therapy in the second-line setting, exploiting the idea of synergy between chemotherapy and MEK inhibitor therapy. There was a phase 1 component to determine the maximum tolerated dose. Those doses are mentioned in the table. No patients had DLT, so the maximum tolerated dose here was 30 milligrams of binimetinib and 1250 milligrams per meter square of capecitabine, given days 1 through 14 in a 21-day cycle. Patients were required to submit their tissue for assessment of RAS, RAF, MEK, and ERK alterations. A total of 34 patients were enrolled to this study. The overall response rate was about 20%, and the progression-free survival was 4 months. Of note, historically, the overall response rate to single-agent chemotherapy based on ABC06, actually dual-agent chemotherapy in that study, was about 5%. The single-agent response rate to binimetinib based on the previous studies, or MEK inhibitor therapy, was about 10%. Here, the noted response rate was about 20%. 12 patients in this study had prior 5-FU exposure, and 4 patients had prior 5-FU failure. Of those 4 patients, 1 had a partial response and 3 patients had stable disease. The progression-free survival in the total population was 4 months, and the overall survival was 7.8 months. 26 patients were able to get NGS testing. Of them, 10 had mutations, 7 patients with KRAS, 1 patient with NRAS, and 2 with MAP2 kinase mutations. In this study, ampullary cancers were included in the cohort of patients. When comparing response rate and progression-free survival, it was higher in patients who had MAP kinase pathway mutations than those patients who had wild-type disease, as shown here. The progression-free survival was statistically significant, 5.4 months in mutant subtype and 3.5 months in the wild type. Similarly, the duration of response and the overall response had a trend towards improvement in outcome for patients who had the mutations compared to those who had wild-type disease. Assessment of response based on the location of the tumor was not reported in this study. Looking at these results altogether, there does seem to be activity of MEK inhibitors in biliary tract cancers. Activity of binimetinib and capecitabine together is very encouraging and is likely attributed to the synergism between these two drugs. In addition, although small numbers, here there is an indication of improved response in patients with MAP kinase pathway alterations compared to wild type, raising the question of whether location of the tumor matters, or if we should have another way to select patients and enrich those who have mutations and constitutive activation of this pathway. Now, looking at BRAF mutations in biliary tract cancer, the results of the biliary tract cancer cohort of the ROAR study was published last year, and it is practice-changing. Mutations in BRAF genes have been reported in about 5 to 7% of biliary tract tumors. The Rare Oncology Agnostic Research Basket Trial was designed to assess the activity and safety of dabrafenib plus trametinib combination in treatment of patients with BRAF V600E mutated rare tumors including biliary tract cancers, GIST tumors, germ cell tumors, anaplastic thyroid, certain gliomas, and certain hematologic malignancies. It was an open-label, single-arm study for patients who had no other therapy available. Objective response rate was the primary endpoint. 43 patients were enrolled onto the biliary tract cancer cohort. The reported objective response rate in those 43 patients was 51%. Overall survival was 14 months, and progression-free survival was 9 months, showing very promising clinical activity in this patient population. How about other ways to target the MAP kinase pathway? What else is going on in biliary tract cancers and MAP kinase pathway? Now, we know there are G12 targeting drugs that are coming into the field. This mutation is very rare in the biliary tract cancers. The GI cohort results of the phase 1 study of Amgen 510 for KRAS G12C mutated cancers reported stable disease in one biliary tract cancer patient. This was reported in the November at ESMO Asia Virtual Conference 2020. There are also ongoing early phase studies with ERK inhibitors and other combinations to target the MAP kinase pathway, results of which are all eagerly awaited. There is use of immunotherapy in RAS-mutated cancers, as well as combination of CD4/6 inhibition along with MEK inhibitors in RAS-mutated cancers for the assessment of response in other tumor types, and extension to biliary tumors is eagerly awaited. So in summary, biliary tract cancers with MAP kinase pathway alterations have been associated with poorer prognosis. Single-agent MEK inhibitor therapy has limited activity in unselected patient population. Chemotherapy and MEK inhibitor therapy may need further investigation. We do have to think carefully about patient selection in this and further investigate biomarkers to identify patients who may benefit. The BRAF V600E mutated biliary tract cancer is one such promising story where dabrafenib plus trametinib has very encouraging activity. Lastly, I want to thank our patients and their families, my colleagues and all the investigators, and the organizing committee for their continued efforts towards improving the outcomes of this very important disease. Thank you for your time. I'm happy to take any questions.